people that did lessons learned. And so Anita asked me if I would be happy to do a presentation about what it entails. Usually it's Mr. Schuber who does it, but he can't at the moment. So I've done that as an F1 and as an F2, and I found it very rewarding, and I hope that it will be the same for you. So the idea behind lessons learned is really for foundation trainees to build a way to look at patient safety incidents, and a way which is non-judgmental, systematic, with a view of taking into consideration human factors into clinical practice and how human factors bring patient safety incidents. So I think it's really, really an important thing in the sense that if you look at people having safety incident happening when they're admitted to the hospital, I think if you go to the next slide, Anita. Thank you. And yes, let's start with that. So patient safety incident. So it's an unintended or unexpected incident, okay, that could have or did lead to patient harm. And the next slide will give you a bit of the context of how important it is in healthcare. So that's quite old data, really, 1999, but you can say that about 10%, almost 11% of people who are admitted to hospital in the UK have got a patient safety incident. So it's really prevalent, 1 in 10 person admitted to hospital in the UK in 1999. And unfortunately, it's not really gone down. It's gone up, but it's gone up in an artificial way. When you look at the latest data, the percentage has gone up, but I think it's just because we're better at reporting it than we were in 1999. So I think it's probably stayed the same in terms of sheer numbers. If to put it in context, so being admitted to hospital is the equivalent of flying for 36,000 hours in a Boeing 747 in terms of the likelihood of having an incident which could or has led to harm. Okay, so we need to get better at looking at why these incidents happen. And a way to get better at it is not, there was a culture historically in healthcare whereby we would blame the last person making the last mistake. And we don't learn from that. We don't learn from blaming. We learn from looking at things in a systematic manner, a non-judgmental way, and say, what can we change? And that's really what lessons learned is all about, is building that way of looking to patient safety incidents and building also the will to share patient safety incident we've been in. Could you move to the next slide, please? Yes, so to sort of summarize what I've just told you. And if you can move to the next one. So the sessions are from memory, and I don't know if this changed, but what we did, we had a session per 3 sessions a year in F1 and 3 sessions a year in F2. And it's structured. So the idea, your role as the lessons learned lead will be to prepare the sessions and to lead the session. So you need to find someone who is willing to present a patient safety incident, and the educational team will find for you a consultant who is willing to act as the facilitator for this patient safety incident. They bring in their experience, their medical knowledge, and also they've participated in many regular M&M meetings. So they're used to this type of thinking. So what you will do, you will be given material, and that is a pro forma, which is this PowerPoint, to explain why the audience is here, what is the aim, which I've just explained to you. And then it can be you, it was me for 2 or 3 actually of the 6 lessons learned that I did, who being the person who present a case, and it doesn't have to be a complex case, just a case where there was a patient safety incident. Then there's a facilitated group discussion, and for that you'll be given a form that you can distribute to the audience. And in this form, there's different factors. We'll look into them in a minute, and how these different domains have contributed to the patient safety incident. And then discussion as a group, so feedback from the group. And then the lessons learned. So what did we learn from this patient safety incident and how we could change things so that it doesn't happen again. And at the end, feedback about what we've learned today, also the involvement of the consultant. And then you have to fill, as the lesson learned lead, a feedback form and evaluation form that you give back to the educational team, and that's fed back to the deanery. So if we move to the next one, please, Anita. So yeah, well, it goes into details of it. So there would be ideally 3 people: yourself, the foundation doctor's lead for the session. That might usually are 2 of you. Then the person presenting the case, and again it can be you, and the consultant or GP facilitator. So that's really important. The Chatham House rules is something to show at the beginning, and to explain that this rule is that we're here first and foremost in a non-judgmental manner, and everything that is said inside stays inside. Okay, and that's really building that safe environment to talk about patient safety incident, and moving away from the environment of not sharing any patient safety incident because of the fear of being blamed. Okay, so it's really important to remember that at the beginning when you do introduction and just before the group discussion. Next slide, please. Okay, so as I told you, this PowerPoint that Anita is showing at the moment will be your framework. So you won't have to create a new PowerPoint. You will just use that as a case presentation, and it can be really, presenting complaints, history of presenting complaint, drug history, allergies, etc., and what happened. And then why did it happen? So that's the next part of you've done the introduction, the person or yourself have presented the case, and the next is to go into the facilitated group discussion. So why did it happen, and what can we do to prevent similar incidents from occurring again? Okay, so if we move to the next slide, you'll have a list of the contributory factors, and they've divided up into different domains. As you can see, there's patient factors, team factors, etc., etc. Okay, and displaying that on the screen and distributing the next slide, please, which you would distribute to your audience, which while displaying this previous slide on the screen, and for them to write down, patient factors was the fact that they could not communicate, for example, and team factor was the fact that there was miscommunication within the team. I hope you get the gist of it, and then what can be done about it. Okay, and at the end you've got the feedback and evaluation that you discussed with the audience on the day. And next slide. Yeah, thank you. And then so a feedback for you as well, because it's also important for you to put that into your portfolio, show that you've been involved in patient safety. And I don't know if there's is that the last slide? There might be the last slide. Yes, and as
that's the last one.
That's the last one. Thank you. And as I explained, you will, if you can open the documents one, please, Anita. Yes. So I think what I'll do. So these are the different, and I think in the documents there should be something about the feedback that you need to send as the lessons learned lead. So the very first slide is about the job that you need to do, and it's quite self-explanatory. And then from the next slide is this is the one. This is what you need to fill in when the session is finished, and send back to the medical education team for them to send to the deanery. So I think what would be useful, rather than talking a bit theoretically, is to give you an example of one of the lessons learned, which I did. So when I started as an F1, one of my first medical on-call, we had a 79-year-old lady. That was my case presentation. 79-year-old lady came in with abdominal pain was found to have a mass in the left iliac fossa. She had an AKI, so we prescribed some IV fluids. That was during the night, and at the end of the second night, middle of the second night, it was the 3 nights in a row. Middle of the second night, we are called to the patient who was in acute pulmonary edema. That was dealt with what you would expect, IV furosemide, oxygen, and the patient didn't come to harm, but could have come to harm because of it in terms of long-term harm. When we look back at the drug chart, it appeared that I had prescribed the first bag of fluid. The SHO on call had prescribed a second bag of fluid before going home. And when we handed over the patient in the morning, we didn't discuss what had been prescribed. She also had been given 2 units of red blood cell during the day and a further bag of fluid. So she had been given 3.5 liters when she became breathless with acute pulmonary edema. So it was very busy during our night shifts, and they were short of an SHO on call during the day. So you can see there's several factors there that we can talk about. If we just say, oh, it's because the last person didn't check that the patient was overloaded before prescribing IV fluids, it's right. That's one of the factors. It's not the only factor. One of the factors is I was a young F1, not much experience on call, just with the reg overnight. The SHO was very busy on the ward. We were not good in communication. The team factor, handover, poor communication with the day team about how much fluid she had received. Third factor, lack of an SHO on call. So there's a staffing factor, which led to people being rushed on their feet, not taking time to go and review the patient before prescribing fluid. And then we can also talk about the fact that it's a paper prescribing system, and you could imagine that with an electronic prescribing system, you would have maybe an alert coming in when you want to prescribe fluid. Have you checked the status of the patient? Are you sure you want to prescribe fluid? They've already had that many liters in 24 hours, etc., etc. So as you can see, there's more than just one factor, and really the idea of these sessions is for people to think a bit out of the box, or to think of the different factors that can contribute. And there's a whole list of factors, whether it's work environment, whether it's the organizational management factors, team factors, individual staff factors, the task, if you had multiple tasks to do at the time and you forgot something, for example. So I hope it makes sense. It illustrated with an example that really your role is to facilitate the session, to explain what the session is for, to either find someone beforehand that would be willing to share a patient safety incident they've been involved with, or present one yourself. Remind the audience that it's a safe environment, it's non-judgmental, everything that's discussed stays in the room. Let the consultant be involved and explain from their point of view, with their experience, what can be learned from it. Review the factors, different factors with your audience, and come to a conclusion of the things that could be changed in the future. And really, it's really starting to build that view of we need to share the mistakes that we make, and we need to share more specifically the things that could have led to harm. And we need to do that in a non-judgmental fashion if we want to improve on that. Right. It's quite a very quick whistle-stop tour. I hope that it makes sense. If you have any question, I'm really happy to try to answer them, either on the chat box. I think that some of you don't have a microphone, or if you want to speak. I don't have access to the chat box, so if there's something there, could you please relay the question?
I can see that, Cyril. I'll let you know.
Thank you.
Oh. Yep, someone's typing.
Yeah.
What happens with the information sent to the deanery?
Well, so I'm not sure is the honest answer. I think it's sent by the medical education team. So maybe Anita, you're able to answer.
Yeah,
that.
I mean, recently we haven't been sending it to the deanery. It was lessons learned. They want us to action this and have it within teaching, but they used to have their own facilitators that used to come in, but since then they've not wanted to. So it's really for us to continue running it in-house.
Okay.
So it won't be sent to the deanery.
Okay, so you can scrap that from what I've said then. It's not going to be sent.
Oh, thanks.
I've got a question as well, actually. So he said the sessions are 3 monthly, are they?
Yeah, so we used to do one per term or so.
Yeah, there's one towards the end of each rotation. I've sent you the dates, Dominic, that I've put them in.
Okay, so
But if
we
there's a
have
problem,
dates in the book already, do we?
yeah, within the core
Okay.
teaching.
Yeah.
But if there's a problem,
Okay.
let me know.
Yeah, perfect.
What I've found in the past is that it's difficult. The first one is quite difficult to find someone to present something, just because they're not really sure what this is all about. And if you've got we all have been involved one way or another in patient safety incidents. So if you've got one you're happy to present, it's quite good to do it yourself, because it shows to others that actually you can talk about this kind of thing. It's not taboo, and it encourages people to actually do it later on.
I've also got Mr. Mackey, one of the consultants, coming along to facilitate the first one. So normally I'll put you in touch with them to have a chat about the case.
Yeah, well, I had Mr. Mackey in my last lessons learned as an F2, and it was brilliant having him. Yes, he's really very approachable with any question you would have, and very good feedback about different things and different factors that contribute to patient safety incidents.
And is it aimed, so all our sessions be aimed just at the foundation trainees?
Yes, so usually what can happen, especially in F2, is that you get SHO, so you get the staff grade, for example. They come and well, they participate in the session, but you won't have a registrar coming in. It's really so either the F1s or the F2 plus SHOs,
Okay.
which, yeah.
Perfect.
I hope it makes sense. When you get, I don't know if you've had, but when you get the documents, it will make more sense.
I'll send them today.
Yeah. So the PowerPoint that Anita showed is really your go-to. You don't need to create anything else. You just need to adapt this one. And then the documents that you distribute, that you give to the participants, the first part is very good for you, just to structure your presentation. Any other question?
I think you've covered everything for me.
Okay, thanks.
Oh, someone's typing. Same here, thank you.
All right. Okay.
Thank you ever so much, Cyril, for taking time to do this.
Right. I've tried
Appreciate it.
to be quick, because you know me, Anita, I'm very, very passionate about that, and I could go on for hours, but I try to be quick and
straight and to the point. Excellent. Thank you ever so much, and I'll send you a certificate.
No, thank you everyone, and hope you enjoy it as much as I did.
Yeah, thanks a lot.
Thanks all.
Bye.
Cheers. Bye-bye.
Bye, Cyril. Thank you.